Ladies and gentlemen, firstly I would just like to say my thank you to the organising committee, particularly to Dr. Mahant and Dr. Puri, and of course to Fortis for the kind invitation to speak at your symposium today. So as a cardiologist who's practiced in the USA, UK and now in Australia for over 20 to 30 years, I'd like to talk to you about something that most cardiologists are dealing with, problems of patients after tetralogy repair. I'd just like to walk you through a classical kind of patient that we would see, a patient who's had tetralogy repair perhaps 20 years ago. You'll see what seems to be relatively good left ventricular function, but with an enlarged right ventricle, and relatively thin right ventricular anterolateral wall with what might seem to be mild to moderately reduced right ventricular contractility. The interventricular septum is intact, and you might note that the aortic root might appear mildly enlarged. Focusing on the interventricular septum, there does not seem to be any obvious ventricular septal defect. Aortic valves and mitral valves appear normal. When we look at measurements of the aortic root, you'll see mild enlargement of the aortic root, and particularly when we look at the right ventricle on M-mode function, you'll see the thinning of the right ventricular anterolateral wall, the relatively poor contractility, the flat interventricular septum with paradoxical interventricular septal wall motion, but good left ventricular posterolateral wall motion. The right ventricle, you can see, is clearly dilated. We get a good view of the wall thickness. We're seeing that the tricuspid valve, the annulus, appears dilated, and that there is mild tricuspid incompetence. The right ventricular outflow tract has been very well relieved by our surgeons. You can see no significant subpulmonary stenosis. The pulmonary valve also appears to be well relieved, but you can clearly see what seems to be quite severe pulmonary incompetence. We can see that the branch pulmonary arteries are widely patent. We can see almost pan-diastolic reverse flow emanating out of the branch pulmonary arteries through the pulmonary valve into the right ventricle. The Doppler shows a strong signal of pulmonary incompetence with rapid diastolic runoff, all strongly supportive of a severe degree of pulmonary incompetence. The right ventricle is dilated. The tricuspid annulus is dilated, and tricuspid incompetence is seen. And looking at the right ventricular outflow tract again, you can see the severity of pulmonary incompetence with no residual right ventricular outflow tract obstruction of note. Tricuspid incompetence shows that the right ventricular systolic pressure is low, with a tricuspid incompetence jet of just over 2 meters per second. And when we look at tricuspid valve annular tissue Doppler, we note an abnormal E prime ratio, E prime wave, relatively low, suggestive of right ventricular diastolic filling abnormalities. The kind of patient that we would very frequently see. So when we look at the problems following tetralogy repair, pulmonary incompetence, by far the most important. Malignant arrhythmias and aortopathy I'd like to address a bit later. I'd just like to make a comment about ventricular failure. We all are aware of concentrating on the right ventricle and right ventricular failure in the late term. But we are aware also that sometimes some patients develop left ventricular failure related to the marked enlargement of the right ventricle, the abnormal interventricular septal wall motion. So important parameter is the persistence of right ventricular hypertrophy. Right ventricular hypertrophy is a good prognostic sign. Thinning of the right ventricle and dilatation of the right ventricle, clearly a poor prognostic sign. This matches well with tricuspid annular dilatation and the development of tricuspid incompetence. And I do believe that tricuspid valve tissue Doppler and TAPSE, tricuspid annular planar systolic excursion, may be earlier markers to help us pick deteriorating right ventricular function. We would also be looking at the right atrial size and looking at reverse flow in the hepatic veins. But of course, we would be wanting to confirm the adequacy of surgery in terms of removal of residual, removal of outflow tract obstruction, particularly in the pulmonary arteries. Gatsoulis and group have talked about the positive prognostic factor of restrictive physiology with early diastolic flow in the pulmonary arteries, antegrade early diastolic flow seen in the pulmonary arteries, and that this is a positive prognostic factor. And one would also be looking at the aorta, both in terms of its size, patency and competency of the aortic valve. So we're very fortunate nowadays that cardiac MRI has come of age, and it has helped us and acts as a superb tool in association with echocardiography. It allows us to view difficult anatomy, particularly pulmonary arteries, branch pulmonary arteries, to look at pulmonary and systemic veins, and to look at the aorta. But without question, its strongest value is accurate quantitative assessment of both right and left ventricular ejection fractions, both at rest and with exercise. It can also help in looking at residual shunts, and certainly very useful when artificial material defeats ultrasound, such as conduit assessment. So the problem of pulmonary insufficiency. With echocardiography, we can often make very good qualitative assessments. Our quantitative assessment of the effects of pulmonary incompetence, not so accurately measured on echocardiography. One needs to consider the importance of the initial corrective surgery, and I'll come back to that in a moment, and similarly the indicators for valve intervention with pulmonary insufficiency. But before I move on to that, I'd just like to make a comment about surgical and non-surgical valve replacements. There's been such a marked improvement in the availability of valves, and the question between bioprosthetic valves and homographs, I think, still continues on. But I think that we should now consider that non-surgical pulmonary valve replacement is beckoning, that Bornhofer and his group have listed a series of indications for the non-surgical pulmonary valve replacement for tetralogy. So indicators for pulmonary valvular intervention. I think without question that we would all agree that symptoms are by far the most important marker, but anybody who has symptoms at rest or symptoms with exercise are clear indicators for valve intervention. But without question, I think that the emphasis is on right ventricular dilatation and function, and not on the severity of pulmonary insufficiency. We would see severe pulmonary insufficiency in most of our patients, but it's the right ventricle that we're most interested in deciding about pulmonary intervention. QRS duration greater than 180 milliseconds has been shown to be an important prognostic factor in terms of pulmonary insufficiency and right ventricular dilatation, and should be an indicator for pulmonary valvular intervention. And the presence of important ventricular arrhythmia is clearly another indicator for pulmonary valvular intervention. The influence of the initial corrective surgery, and I think that most institutions would agree that we see by far most complications occurring in association with extensive right ventriculotomies and transannular patches. In our institution in Melbourne, we've been using the right atrial transpulmonary repair since early 1980s, and I would like to present our sort of findings at the end. but in some cases conduit insertion has been necessary, and that clearly will have an important factor in terms of the need for conduit replacement and pulmonary valve replacement. The more recent surgeries of infundibular and pulmonary valve sparing surgeries, I think it's really a little bit too early to make much in the way of comments in terms of long-term outcome, but my feeling is that without question infundibular sparing surgery and pulmonary valve sparing surgery allows much earlier repair, but we're clearly seeing a significant reoperation rate. And I think the proof will be in the pudding that we may well still see significant pulmonary insufficiency in the long term. So those patients that have important arrhythmias, we're aware that age and coexisting abnormalities is an important prognostic factor for the development of arrhythmias, that the type of repair, a repair that involves a significant ventriculotomy, that a repair that leaves significant residual pulmonary stenosis, whether it's at subvalvular, valvular or supravalvular level with greater than 60 millimeters mercury. And in most cases, those patients that also have severe residual pulmonary incompetence. But again, I believe that the emphasis should be on the right ventricular dilatation and the ejection fraction. That ECG Holter and exercise testing will help us pick those patients who are most at risk for malignant arrhythmias, and that again we should be aware of the concern about very long pure rest duration. And occasionally, some of our patients will develop aortopathy. We're aware that this is most likely to occur in a select group. Patients that have tetralogy with pulmonary atresia, those patients with DeGeorge syndrome, male patients over female patients seem to have a higher preponderance, except for female patients that have had pregnancy. Patients with right aortic arch and who have had previous palliative surgery as a shunt. And I'd also like to just mention, not on the slide here, those patients who unfortunately also have a bicuspid aortic valve. So we have a risk of aortic dissection. I think we would all agree that an aortic diameter greater than 5.5 centimeters is a high risk for dissection. But clearly we would not always be waiting until that time. That cross-sectional area of the aorta in two orthogonal planes over the height with a level greater than 7 would be considered to be at risk and requires regular follow-up, and certainly greater than 10 ratio has a high risk of developing aortic dissection. And that those patients where the annual progression of the aortic growth is greater than the Z-scores should clearly be closely followed. And I do mention the importance of beta blockers, and that without question this is of value in protecting aortic root dilatation and dissection. So having said all that, I would just like to spend the last minute or so looking at our results from Melbourne, Australia since 1980. So we've got about a 25-year experience. And looking at our late follow-up, and these are very current results, not yet published, that if we were looking at the freedom from reoperation at 20 years, we're generally talking about a 75% freedom from reoperation from any type of reoperation. Clearly, those patients that have residual outflow tract obstruction, pulmonary artery stenosis, have a relatively low risk for freedom reoperation, perhaps 95 to 98%. But it's those patients with right ventricular dilatation and pulmonary insufficiency which bring our figures down to perhaps around about 90%. If we were to look at our patients in Melbourne in terms of survival from tetralogy, 25 years down the road, we would say that their chances of survival are excellent. We're quoting a 95% survival rate around 25 years. And if we were to be looking at our patients who have had only a transatrial repair, not involving any significant right ventriculotomy, and survival and late follow-up, perhaps it's around about a 97% survival rate. So, in conclusion, can we offer good news to our patients? I do believe yes. Our surgeons have been very skilled. I think the results are good, and there's every reason for a cautious but good outcome for our patients following tetralogy repair. Thank you.